need someone to talk to and you don't know what to do, call us 214-4400 when you're feeling all alone and they turn their back on you. Call us 214-4400. Call us 214-4400. Call us 214-4400. Call us.
Welcome to the Kind Counseling Podcast. I'm your host, Dania Roberts. Once again, we are here to give insights and share information, as well as bring light to various topics that affect our communities at large. Kind Counseling is a mental health practice that gives hope to the hopeless through mental health empowerment and spiritual insight. And today we have a great show for you. We are talking to a surgeon, not just any surgeon, okay? A cardiothoracic surgeon, okay? It's a special dude. All right, so before we bring him out, let me just tell you a little bit about our guest. He is born and raised in Brooklyn, New York, went to Brooklyn Tech High School, yeah, Tech. He went to NYU for undergrad, majored in chemistry, did a post-baccalaureate program run through at the College of Medicine at Ohio State. He went to Mount Sinai School of Medicine and got an MD with distinction in research. He then went on to do general surgery residency at UMD, New Jersey, and then did a cardiothoracic surgery fellowship at NYU Medical Center. He's been in practice for 11 years, first in New York and now in New Jersey. Let's welcome Mr. Dennis Vega.
Hello,
How you
everyone.
doing, sir?
I'm doing fine. How are you?
Good, man. He's a real relaxed guy, man. So Dennis, man, tell us Dr. Vega, tell us a little bit about, your background and, where you come from, and tell us a little bit about yourself.
Like you said, I was born in Brooklyn, New York. I lived a little all over Brooklyn. I think I was first Brownsville, which I don't remember because I think we moved from there to Coney Island probably when I was about 2 or 3 years old. My father's from Puerto Rico, my mother's from Costa Rica, but her family, I guess, originally immigrated to Costa Rica from Jamaica. Probably, I guess in the 1850s when England freed the people, and so they sort of scattered into Central America, and so I have family in Panama and Costa Rica and all in Central America like that. So after that, just sort of growing up, and my mother took ill. And I wound up going into foster care in Brooklyn, and the family I was with was great, and they, pushed education on me, and so I did all those things. Became interested in science, and did some sort of one of my foster sister's husband was a chemist, and sort of got me interested in chemistry, and I guess that's what brought me into chemistry at Brooklyn Tech. And then from there, I decided, to continue in the science field, and I went into to NYU, became a chemistry major there, started working in a laboratory, and then I realized there's no people in the laboratory. So that's when I decided to pursue medicine, and so then with that, I had to, I guess, get some other courses underneath my belt in order to get myself into medical school. And I got into this nice program that was run through the College of Medicine in Ohio State. And with that, that propelled me into Mount Sinai, which got me back to New York, which is great. And then while at Mount Sinai, I got a research fellowship there. And that's how I was able to graduate with distinction in research from Mount Sinai. Mm-hmm.
So now you mentioned foster care, right? Yeah. How old were you at the time when you went into foster care?
From 7 to about 11. From age of 7 to 11.
Okay, so I mean, can you tell us a little bit about that? Is that I mean, just what your experience was like, or?
Oh, there were The experience was overall good. Surprisingly, I think most kids are like, "Oh,
Right.
it's terrible." But the my mother took ill. My father couldn't take care of four boys at the same time in work.
Mm.
So we unfortunately we had to be split up because nobody was able to take four boys. So two of us, me and my youngest brother, went with one family, and my older brother, my other younger brother went with another family. And the first family I was with, it was not a great environment. I actually wind up running away from there, and that's
Really?
when, yeah, I was there for about 6, maybe 7 months. I just hopped on the train and went to my father's house. So that was, I don't even quite call that running away, but
Wow, that's
but
crazy to hear.
I was seven. I was seven when I did it, so everybody makes a big deal of it. And so that got us into the other family, and it was a very nice family. The mother was actually Puerto Rican, and the father the father was I guess half African American, half Yemenese. So he was a practicing Muslim, and
Okay.
it was a very interesting environment with the Puerto Rican and the Muslim together. But it worked for them, and they raised five daughters together,
Wow.
and I still consider them my family, my sisters,
Mm.
and we stay in touch regularly. And my foster
Wow.
father is still alive. He's 90, yeah, 96 now, I believe.
Wow, really?
Still living in the same house in Brooklyn. Yeah.
Wow. So, and I mean, that's great that you said that. I mean, because like you said, you hear a lot of, negative stories in foster care. And so
Mhm.
they exposed you to like either the idea of medicine or the idea of
No, just more of just pushing education. My foster father's a graduate from NYU as well.
really.
He worked for New York City Housing Authority, and became a pretty I guess went up to a high level there. I think eventually deputy director or something like that. But it was always about education. Just it doesn't matter what you do, but just still focus on education and learning, and you'll figure out what you want to do and what you want to go into later on. Mhm.
Okay. So when would you say you knew you were going to be a surgeon or you knew you wanted to be a surgeon?
Oh, that that took some time. So when I first got into medical school, I thought I was going to go. I always liked dealing with kids and working with kids, so I thought I was going to become a pediatrician. Then when my first class, of course, they teach us. One of my first classes was in medical school was embryology, which is the development of the human body, and it was actually taught by a pediatric surgeon.
Mm.
And I was like, wow, this is pretty interesting because he showed us both sides, like I guess the abnormal formations, and then what he does surgically to fix them. And then me and a few of our other classmates made an elective, and we followed him around and things of that nature. And that's what piqued my interest in surgery. And then I started doing some other electives in surgery, or in the surgery that had surgical undertones to it, to figure out if that's really what I wanted to do. And then I also did some electives in pediatrics, also to see, to make sure that I was making the right decision. Even though you could change it later on, but still, you want to try to do what you feel is best for yourself. And so with that, I decided to do surgery. I think a lot of people were surprised that I went into surgery. I
Mm.
still remember when the match, we do a match process. When the match came out, and I wound up getting into UMDMJ in Newark, New Jersey. As one of my friends was like, I was like, oh, where'd you match? I was like, oh, like I matched in UMD for surgery. He's like, I was like, what? And then he was like, but you're not an a-hole. I was like, I
Okay.
was like,
Wow, really?
I'm sure there's some nice surgeons out there. I won't be
Wow.
the other. I won't be the only one.
Okay.
But people have a particular, idea of the personality of a surgeon, and so I think that's what it is. But I enjoy but I enjoy what I do, and I think it's fun and interesting, and I get to help a lot of people.
So all right, for those that don't know, what does a cardiothoracic surgeon do exactly?
Well, we take care of the, I guess, preoperative, before surgery, during surgery, and post-operative or after surgery care of, surgical patients that have issues in their chest. I particularly focus on non-cardiac thoracic surgery. So I don't do like bypasses, heart valves, or anything like that, but I deal with everything else in the chest. So I deal like with a lot of my cases, I deal with lung cancer, esophageal cancer, infections in the chest, other types of tumors in the chest wall issues, airway issues, hernias in the chest, and things of that nature. So I do all of the other stuff besides the heart.
You're listening to the Kind Counseling Podcast. Feel free to hit the like button and subscribe to our YouTube channel. Now back to the show. So in terms of like you said, you work inside the chest. Like, so what are some of the reasons that people have like problems within the chest? Like what leads to that?
Well, one of the main culprits, I guess, is lung cancer. But still, despite all the warnings and everything else, there's still a lot of people that smoke, and that usually winds up bringing up a mass, a nodule is found on an X-ray or a CT scan. Where we've been doing, I guess, CT scan screenings for smokers for probably about 10 to 12 years now. So that's in place in a lot of different facilities where, if you have a smoking history, you can get a screening CT scan of the chest. They can hopefully find nodules earlier, and then we can either follow them or take them out or biopsy them as well.
So in terms of smoking, that's smoking anything or primarily cigarettes you're talking about?
Primarily cigarettes. There are some genetic components to it, but it's mainly environmental with smoking. But there are some patients that do develop, cancer without a history of smoking. Some people who worked dealing with the asbestos in the past and things of that nature, that they can develop cancer as well. But different types of cancer, that's more related to mesothelioma as opposed to directly to lung cancer. But sometimes the combination of smoking and exposure to asbestos can lead to an increased risk of getting lung cancer.
All right. So now, if you could be honest for a second, do you remember the first time you saw inside the human body?
Oh yeah, that was medical school when we did our dissection courses and with human cadavers.
What was that like? What was that like?
I for me, I thought it was great.
You thought it was great?
It was great because, like,
wow.
it's a weird experience because actually for my school, a lot of the cadavers we had, those people actually donated their bodies particularly to have that done at that school. At Mount Sinai. So it's so we took special care to protect the body and not just have it completely exposed and only expose the areas we're operating, I guess dissecting at that point and things like that. But that was when you start going through the body and learning all about the body, starting with the extremities and then working your way inside and things like that. I thought it was great. And some people, got a little queasy with it, and some people decided at that point that this is not for them. But I enjoyed it. Like I said, I signed up for an elective, which was surgical anatomy, which we did operations on cadavers. So we did like a particular operation on a cadaver, which is good as well.
I've heard it said that like psychiatrists are frustrated surgeons. Is that what? Or maybe they go ahead.
I haven't. I don't think I've heard that one.
or meaning like people who couldn't hack it in surgery, they go to psychiatry. I guess I don't know. I mean, I heard that once. I don't know. But all right. So now I was doing some just some research on what exactly you do, and as soon as I heard you guys cut people like the breastbone with a saw, is that what you do?
Yes, that can happen. Most of my surgeries happen between the ribs.
Okay.
So a lot of my surgery I do with the cameras and small instruments, and also the use of the robot.
Okay.
So I make small incisions. I put little ports in, and I go in between the ribs and do the operation that way. When we're doing open heart surgery, we do have to do a sternotomy, which is that cutting of the breastbone. in order to do the heart surgery. Sometimes, you know, the operations we have to do, like to deal with an airway tumor or a tumor in the mediastinum, which is the central portion of your chest. We have to go through the sternum in order to do that.
So all right. So as soon as I heard that, I paused the video and I stopped. I guess I wouldn't make a good surgeon, but I'm just saying, I just like froze, man. The idea that you're sawing somebody's breastbone like open.
Yeah, you have to get to the space in order to do what you have to do, and then you bring it back together.
So obviously you've been doing this for a long time, so this is like no big deal. Oh my goodness, man.
It's still exciting every time, though, believe it or not.
So wait a minute. So did you watch like horror movies as a kid? Like, I mean,
Oh yeah, definitely.
So you're that guy. You probably rooted for Jason, right? Like in the movie.
No. I was not rooting for Jason.
Oh my goodness, man. Well, yeah. So, all right. So now the other thing is this I wanted to ask you about too. You're in a field that's, I'm assuming, predominantly white. The further up you go, is that accurate?
Yes, for the most part, yes.
So what is that like for you, being you know, an Afro Latino male? Like what's that like?
Well, I mean, you know, you always have to be on your game and you know, present yourself well. So because there's people that have certain ideas in their mind of you know, that's, or you know, oh, he doesn't belong here. He doesn't, you know, particularly, I mean, maybe he got help in order to get to where he's at, but you know, and then, you know, but when you look at my record and everything that I've, you know, every place that I've been, you know, I've done well. And, you know, I went through NYU Medical Center for Fellowship, which is one of the premier fellowships in the country, and things of that nature. And then they look at that and they see that I do, you know, a very good operation for patients, and they get over that. You know, there are some patients that also still have in their mind that, you know, when you first walk into the room, they're not quite sure why you're there.
Oh, wow.
And then, you know, you introduce yourself and tell them, it's like, no, I'm here to talk to you about, you know, potentially getting surgery. I was called by this doctor because you have this issue in your chest, and I'm one of the chest surgeons here. But you know, for the most part, it's you know, it's definitely, I think, if you think about, I guess, when I started in medical school till now, it's been quite a number of years. So it definitely has gotten easier and better, and very few issues ever arise of that nature. But it's still, you know, you still always have to, you know, be on your game and do your best for your patients.
Okay, all right. So just in terms of I read also that sometimes there's I mean, I don't know what the percentages are, but in terms of success, in terms of surgery and saving people's lives, so that would suggest that you also have patients that don't make it, right? So
Oh, of course, it's
right, so what's that like? Like just dealing with, you know, like it's not a successful surgery per se.
Well, it's you know, usually when I have my discussion with the patient, like a lot of times I deal with lung cancer, so I'll talk on that vein in order to answer the question. So when I'm dealing with the lung cancer patient, I'll explain to them what we're going to do when we get inside there. We're going to try to remove everything. We're going to take out, you know, lymph nodes. We're going to try to make sure that the cancer hasn't spread anywhere and things of that nature. And then once we get the final pathology, we'll know what kind of additional treatment you may or may not need. And you know, and sometimes you go in there and you get surprised with what you find. You know, you think you're going in and you're dealing with one particular thing, and you find that, you know, the disease has already spread. And then you got to tell the patient that later on, after you finish the surgery. And you know, it's unfortunate, but you know, I think a lot of patients don't want you to be hemming and hawing about it. They want the information presented to them as quickly as possible, and you know, with some tact, but not, you know, in a way that you're, you know, either minimizing what we found or overstating what you found. You just say what you found, and you move on, you tell them what we have to do next. And I think they appreciate that. And I think that's why a lot of the patients that I deal with, like how I talk to them and like how I present the information to them and explain everything step by step what we're going to do.
Okay, all right.
But it's difficult to present that information to them that, hey, I found out that, your stage is higher than we expected. And sometimes when we find disease that has spread elsewhere, the stage is high. The stage could be 4, which is the highest. And they, depending on how the treatment goes, could have 6 months to a year to live. So, you talk to them, you tell them the numbers, you tell them the percentages, but you tell them that's for everybody. But, the chemotherapies have changed, all the treatment, options that are available have changed. And there's definitely, things that they can, there's other research that's going on with different types of chemotherapy agents, and you explain that to them. I thank goodness I haven't had too many patients, die on the table,
Okay.
but that can happen. I've had it happen with 2 patients. One was. I was actually done with the operation. We were about to put her back in the supine position, to put her back on her back. And I think most likely she threw a clot to her lungs, which can happen when somebody has cancer. They develop clots in her legs. And we couldn't revive her. And I had to tell her husband what happened. But, he was also, what we found in her chest was a lot worse than what we expected also. So he was somewhat comforted that she didn't have to go through all the chemo and everything else that would have been expected to try to help her extend her life. But it's kind of crazy. You get, I guess when I was a resident at UMDMJ in Newark, I got exposed a lot to, telling family members that their family member passed away. In Newark, there was a lot of gun violence and shootings, and so with that, it's not that you get. I don't want to say I get comfortable with it, but it's just I guess you somewhat get used to it, and you kind of like learn in a particular way how to present that information. You also have to judge, who you're talking to and how they're responding in order to how you want to present that information. But once again, you try to present it to them in, a comfortable fashion, as comfortable as you can make it, and not without, because a lot of, I guess, doctors may start explaining what was going on, and you just have to come out and say, look, unfortunately he didn't survive. And then if they want explanation, then you explain it to them. And I think they appreciate that more than going through, going through hoops and going through a long-winded story to get to the final point that their loved one is dead. So, but it takes some practice doing it, and with the field that I'm in, especially with lung cancer, you deal with that, and then we also I also help with patients that have spread of cancer to their chest from other locations, especially like with breast cancer. So I deal with a lot of those patients as well, helping to control fluid in their chest that develops. And I've had some wonderful people that I've met pass away, and it's always very difficult to find out that they've passed away. But on the other hand, you get a lot of patients that you help, and
Right.
I remember there was a patient. I never saw him standing up. Like I got called for him, and like they biopsied a mass in his lung, and he just kept bleeding and bleeding to his airway. And I spoke to his son. We took him to the operating room to try to get the bleeding under control. I got all the clots out. It seemed like it stopped, but then when I put the camera back into his airway, all the airway filled up with blood again. I went out there and told his son, look, I gotta go, and I gotta take out this mass. He's just gonna keep bleeding. And so I then did the operation, which took a few hours, and the guy did fine. And he went to the ICU, and I think I was on vacation that week, so I left, and by the time I got back, he was out of the hospital. And then one day I'm in the office, and I saw a name on the schedule. I was like, wow, who is this patient? I'm trying to remember. And then I opened the door for the patient to come in, and he just comes in and just gives me this big old bear hug. and I recognized his son.
Oh,
He
wow.
like lifted me off the ground,
Oh,
and he
wow.
just said, he just thanked me, said, "Thank you for saving my life." And I was just like,
Wow.
"Oh wow, you're welcome." I was like, "Oh my God, you look amazing." He had
Okay.
lost weight, and he looked great. You know, he was doing so well, and everything turned out great with the with the stage and everything. So you have both spectrums. The great, wonderful stories where you help somebody and you help them extend their life, and you have others where you help them, but you're unable to get them extend their life any longer. But you do the best you can on either end. Mhm.
That's good, man. That's good. It sounds pretty very rewarding.
Yes, it is. It is.
So now during at some because I have a lot of clients that worked in hospitals during COVID. So
Mhm.
what I guess for you, you were still doing surgeries during COVID, or you had to stop and focus on that? Like
Well,
what? Yeah.
yeah, initially the what they did was they stopped the elective surgeries. So anything like, let's say, like a chest wall hernia or things of that nature, those things all stopped because they're like more elective than. But if there was a case that was dealing with either the diagnosis or the staging of, let's say, a cancer, then they would still allow us to do that. Some patients outright refused to even entertain going into the hospital during COVID. So
Wow.
there was one lady, I said, "Oh, we have to biopsy this lymph node to see where there's positive, and then that will determine if you need chemo." She was like, "Just give me the chemo. I'm not going into the hospital." I was like, "Are you sure you want to do that?" I mean,
Wow.
I was like, "I'm not going into the hospital." I was like, "Okay." And so she went down the route of getting chemo. but with that, I also started helping out with in order to to help out. You help out with the patients that are in the hospital dealing with COVID, and I was
Mm,
placing tracheostomies with this tube in the airway.
mm.
And so if they're like were on the ventilator for a long time, they needed a tracheostomy that was placed, and I helped place feeding tubes and things of that nature to help those patients that were dealing with COVID.
Okay. All
So
right.
I never stopped.
Okay. Okay. All right.
During COVID.
So I mean, you I mean, I've just heard so many stories about medical health professionals. Just seeing, like one guy said to me, he's a respiratory therapist, and
Mhm.
he said he saw more people die in during that time than his whole professional
Yeah,
career.
it's it's true. I think for me as well, because a lot of patients were coming in, and they just you just see them spiraling, you know, getting sicker and sicker, and then it reaches the point that they can't get ventilated, they can't get oxygenated. And it just keeps spiraling down from there. And that was the unfortunate aspect of it. And then we gradually started learning more and more about it, and it was then we were able to help them a little bit more with certain treatments, but it was still, you weren't sure. Those patients that had a lot of comorbidities, like the obese
Right.
patients, diabetics, heart disease,
Mm.
kidney disease, those patients fared the worst, unfortunately. um, and so there was a lot of patients that had but there were a few that that were on the ventilator for a long time, and they made it through.
Mm.
But there was a vast majority, and then gradually as vaccinations started, you saw that the numbers were changing. Like before, it was like all unvaccinated patients coming in with COVID, right? And then it was vaccinated patients. Very few. Then there was very few that were vaccinated that were coming in with COVID and requiring, being on the ventilator, et cetera, and requiring, significant, critical care and things of that nature. And then a lot of the patients that were there, it was like 85 to 90% were unvaccinated patients. They reached that point after the vaccinations were rolling through. So it
Mm.
seemed like the vaccinations were working, and the hospitals then began to stop getting overwhelmed by, with all the patients being admitted because of COVID. So it was definitely a good change. I mean, we still see the occasional, COVID case that goes further south and requires ICU care and stuff like that, but not too often anymore, which is good.
Okay. All right. Now, obviously, you have a very high pressure, demanding, high stress job, right? So,
Mm.
what does Dr. Vega do for his own mental health and self care?
You have to take breaks. And when I have so I have I'm divorced. I have my kids every other weekend, so I'm usually off when I have my children, and so we just plan to do stuff. We go out and do different activities. I try to do outdoor activities. Whether it's mini golf or going to the park, bike riding,
Okay.
things of that nature. That's what I try to do. So spend time with family and friends. I try to travel. Usually, if I get a weekend that I'm off and I don't have the kids, I'll schedule multiple things to do just for myself. We work out. A lot of different things. Like I do some cooking and a little bit of baking. So all of those things help with keeping your mind fresh and recharging, and either with family, friends, or both.
Mhm. So let me tell me something about, because every profession has its, well, idiosyncrasies, right? There's little issues and stuff like that. What is something about surgeons that most people don't know?
That most people, I'm sorry, I didn't.
That what is something about surgeons that most people would not know?
Uh, I think for the most part, most surgeons are listening to music in the operating room.
Okay.
No,
Okay.
but there's actually been a report that has come out that shows there's no detriment to the patient with the music being played. It actually speeds up the amount of cases. It actually decreases the operative time depending on the type of music that's being played. If it's
Really?
a slower type of music, you lose some time for the operation. But if it's a faster type of music, then the time actually decreases more. So I think for the most part, most surgeons do have some music playing in the operating room. I do. I
So,
do all the
so,
time.
so I'm gonna ask you, right? Like, what's like your favorite song to operate to?
Well, I have a variety. I don't have a favorite song, but I have a bunch of playlists that I play in the operating room. So one of the first playlists I ever created, starts off with Bob Marley and the Wailers, and it goes to
Okay.
it goes to Prince and Lenny Kravitz, and
Really?
it goes through a whole variety of music. I put some South in there as well. So I listen to a little bit of everything. And so people get a kick out of the music I play because it's just a whole big variety of music. I put some Latin jazz in there.
Okay.
Some I got to try to keep it, PG.
All right.
So I can't
Well,
play
I was gonna ask.
I can't play everything on my phone.
I got you. I got you. I was gonna ask. I mean, because I'm imagining you like listening to some rap music while you're cutting somebody open. I mean,
Oh yeah, yeah. I usually keep it tame. I do some older stuff, some Tripod Quest and stuff like
okay. All right.
that. But that's a little safer.
I
But
got
there
you.
was one day that somebody, I get the playlist finished, and so they just, I guess, press play for the thing to just do random,
Right.
and I was like, something started coming. I was like, whoa! I was
Right.
like,
Right.
go to playlist number 2. So I have like OR playlist. I think 1 through 8. And then
Okay.
sometimes I'll just tell the phone, I'll play Michael Jackson, and they'll just play all the albums I have from Michael Jackson, and
Okay.
randomly, something like that. So
Oh, okay. 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 Well, listen, man. It's your story is very inspirational, man, and it's
thank you.
considering where you're coming from, like how your life evolved, and where you are now. I mean, I think it's. I mean, do you speak do you do speaking engagements, or like how could people reach you if they wanted to contact you, if you do some of that?
I haven't done any speaking engagements. I've done some talks, I guess, mainly dealing with lung cancer and lung cancer screening and things of that nature. So I talk to groups of people in that way, and then sometimes I present information or I do a talk on a particular topic. So those are usually geared towards more for people in the healthcare professions. But I haven't done any speaking engagements to talk about, I guess, my life and what I've done and things like that. I mainly do that, I guess, with friends and family, some people that that I've met and stuff like that.
Okay.
Just try to hopefully inspire some people to keep it going.
Yeah, man. I mean, well, yeah, I get you on tour, man. You got a great story, man. I'm serious.
Mhm.
I mean, you have a great story. But
Okay.
I mean, listen, man. I just want to thank you for coming through, man, and just sharing your story, and definitely giving us some insight into the world of surgery. I mean, that's not something I know anything about, and I tend to stay away from hospitals, so I mean, for obvious reasons, but
Yeah. No,
but
most people go to the hospital when they absolutely have to,
well,
but
well,
there's always I guess, a certain fear, and I guess I don't know. There's always, I think that the fear is still, even when I was coming up, I guess through medical school and stuff like that, there's still a fear in the minority population, and not a little bit of mistrust, I guess, with
right.
coming to the hospital. What's going to happen? And am I going to get the best care? And but I think most doctors are going to try to do their best for you, no matter who you are, what you look like,
Mhm.
and uh, and I think if you're not feeling well, you got to go and get care, follow up with your regular medical doctor, and keep on top of your health, whether you have high blood pressure, diabetes, asthma, whatever it is. Stay
Mhm.
on top of it. So don't come to the hospital when it's the wheels are falling off.
Right, right.
Come there while the tire is getting a little flat, and then things can be fixed and repaired.
That's good, man. That's good. Well, listen, man. I just want to thank you again, and I got to make sure I post it in the Brooklyn Tech alumni page, man. Letting everybody see what you're doing, man.
That would be great.
That's great, man. But thanks a lot, Dennis. Good seeing you, man.
Good seeing you too. Thanks for having me. I appreciate it. I had a good time.
All right, good. We'll talk.
All right. Take care.
If I ever took a loss, I learned a lesson. I won't ever think I'm better than the next man. I've been down before to come up.